Hello, I'm Dr. John Kruse, and today I'm going to be having a question and answer session. Thanks for joining me. The launching pad for today's Q&A is the video I released a few days ago that was about the stimulant epidemic. Excuse me. So I'm going to recap that in 1 to 3 minutes, and then I'll be open for questions on that topic or any ADHD topic or mental health in general. So the stimulant epidemic has been getting lots of attention because it's increasingly a big problem. Many of us are aware of the opioid epidemic, and whether you count the current stimulant epidemic as the fourth wave of that opioid epidemic or a completely separate epidemic, the number of prescriptions written for prescription stimulants has shot up. The number of overdose deaths where stimulants are a component of what the person took has shot up dramatically and hugely from more than 20 years ago. That was less than 4,000 a year, and it's more than 40,000 a year. Again, that doesn't mean pure stimulant overdoses. Those are still relatively common or uncommon, small part of the total. So the opioid epidemic, the first wave was prescription stimulants, prescription opioid pain medicines. The second wave was a big increase in the use of heroin as there was some clamping down on by legal sources and prescribing sources decreased prescriptions for prescription stimulants, and drug marketers saw a market for their heroin. So that heroin was the second wave. Third wave was fentanyl, a much more potent synthetic opioid, much more likely to kill people because it's so potent. It's hard to calculate what dose you're taking, and it's really easy to overdose. And fentanyl certainly hasn't gone away, but over the last several years, increasing numbers of people are taking opioids with a stimulant, most often methamphetamine. Right now, that share of the overdose market is something above 30%, have both fentanyl and a stimulant in their bloodstream. And the increase is so high that within the next year or two, that will be the biggest component in the substance abuse market or substance abuse overdose statistics. So this is meaningful. It's a large increase. When we look at prescription stimulants, most people are upset and concerned about that we're pushing drugs on kids. Rates of stimulant prescribing in kids have actually decreased slightly in the last decade, not hugely. So all of this increase is from prescribing to adults and particularly women, and those have been historically neglected communities in the ADHD treatment world. So part of why I'm talking about this is one of the policy advisor for the DEA. He has other titles as well. His name is Matthew Straight, has been giving talks online to doctors and other prescribers, several thousand at a time. And it seems to be that they are scheduled to issue new regulations regarding prescriptions controlled substance prescribing. There were supposed to be new guidelines before May of 2023 when the COVID pandemic public health emergency measures were concluded. The proposed measures met with such opposition that they were rescheduled, and for the end of 2023, then they were postponed to the end of this year, and they will be making some announcements before the end of the year, probably in the next month or two. The biggest change is clearly targeted not at stimulant use overall, although it will have a big impact. It is clearly targeted at a specific business model, and it's very clearly specifically targeting the online evaluation and online prescribing market, and they are specifically targeting it by requiring at least one initial visit in person before stimulants can be prescribed. So again, this is very selectively trying to target one business model, whether that will have more consequences that are good or bad or will remain to be seen. They have not yet announced that that will be their policy. They did get more than 38,000 comments as pushback when they proposed that prior to May of 2023. So we will see what they actually do in this country. And what gets done in this country may well be copied or imitated in other regulatory bodies. I have allergies today, so I may be coughing. So I am not, so I'm open to questions. I think several hundred people, a few thousand, actually watch parts of that video. So I am seeing. So Dennis asks, does subclinical, hi Dennis, thanks. Dennis asks, does subclinical ADHD exist? So I think a sweeping generalization, and I'm not usually prone to them, I like to be more careful. I would say absolutely subclinical ADHD exists, and I would say every researcher who has used assessment method that allow for something other than just a categorical, yes, they have ADHD or no, they don't, shows that ADHD does exist on a spectrum. And since it exists on a spectrum, it is actually arbitrary where along that spectrum we decide is a cutoff point between people who are pathological and have a disease and people who just have a subsyndromal, subclinical, subthreshold amount of ADHD. One of the most important papers regarding this was one by Sibley, I believe, came out 2 or 3 years ago. And it was framed a little differently. It was framed as most kids who are followed who have ADHD have periods where, yes, their symptoms seem to be decreasing, but then if you keep following them, they often do re-emerge at a serious enough, either a enough number of different symptoms or severity of the symptoms they have to meet full criteria of ADHD again. So their claim was that most people who have childhood onset ADHD, some are clearly so severely impaired consistently that they, for their lifetime, meet a full-blown ADHD diagnosis. And probably a larger proportion of people, if the situation, if their work or school is supportive enough, if it's not overly demanding, if it's a good fit for their interests, if they have supportive partners and neighbors and housemates and children or whatever, then they may be functioning sufficiently. But if either the support or structure is diminished or the demands are increased, then ADHD may be impairing and rise to a level of clinical significance. So that's a good question, and I hope I answered that. So Danny Dawson says, greetings from the UK. Great. Hi. So I hope this is not what, so I see the first part of a question. So Danny mentioned that he used speed for many years and ended up in prison because of his psychotic behavior. I don't know if there's a, so speed, at least in this country, is the imprecise term, slang term used for methamphetamine. There is a legal form of methamphetamine under the brand name Digoxin that is legal in the United States, but it's always been a tiny, tiny fraction of all stimulants being sold in the US. Vyvanse, Dextro, lysine attached to dextroamphetamine has been the biggest single stimulant for several years. Amphetamine products are more popular in the US than in the rest of the world. But again, the methamphetamine is a separate methyl group added on. Methamphetamine seems to have, by all studies, so I have a talk that meth is not the same as amphetamine. It's in this series, so I won't beat it to death, but meth does seem to have higher rates of addiction, higher rates of psychotic disorder coming out as a side effect of it. My general recommendation, and finally, we are paying more attention to this for 30 years for specific reasons due to my own practice. I saw higher rates of amphetamine-induced psychosis than it seems most other experts did. I would always caution patients before starting or continuing them on stimulants that was a risk. And surprisingly, people from every single one of the most prominent ADHD experts who've written books and talked about this, when I would talk to them about the risk for psychosis with amphetamine products, I would say, "Oh, nobody ever told me before." So I've overemphasized it for years. I think it's good that it's getting more attention. Its current evidence is it's much more of a risk with amphetamine-based products than it is with methylphenidate products. And my strong recommendation is that, and this has not been the angle most people have been looking at, but there's growing research on this angle, is that if you've had a single episode of amphetamine-induced psychosis and you look 15 to 20 years out, about a quarter of those people, 20, 25%, various in different studies, are in a permanent psychotic state. So means that we have changed the brains for some people for the worse in a permanent or semi-permanent condition way. And I am strongly recommend not even retrying any amphetamine-based product if you've had psychosis, even if it was on street meth rather than on amphetamine, because I think the risk of relapse is so high. So Max asks, when will I release my book? So I do have one book out. It's 5 years old. It's called Recognizing Adult ADHD, What Donald Trump Can Teach Us About Attention Deficit Hyperactivity Disorder. I was surprised. I thought we could use that individual as a learning opportunity to learn more about ADHD because he so clearly fulfills objective criteria. I was naive and not correctly assessing how toxic he is to so many people. So the ADHD community, psychiatric professional community, the people on the far right, the people on the far left, all didn't want to hear that book. It's still out there in audio version and hardback and softback and everything. The next book, or the book that I've been working on, is called Attention Deficit World, and it some of feeds right into the question Dennis started with, and that I think we have lots of really good books on ADHD, and they say, here's this nice, tightly defined thing. This is full blown ADHD. We're not going to talk about all these other things that are subsyndromal ADHD or secondary ADHD that comes up because you have COVID or you got hit in the head, or those are distinct and different. And then the other camp, or the other set of books we have out there, is a lot of books particularly focused on the internet, social media, how those are changing and shaping and warping our brain. And they'll go on and on. Some of them focus on depression and anxiety, some focus on clearly executive functions, attention, concentration, impulsivity. And then they'll devote in their whole book a paragraph or two to clinical ADHD. They'll say, oh, this is completely separate. My book is that I don't think these are separate or separable issues, that we need to be looking at understanding what's classic conventional ADHD, what's subsyndromal ADHD, because clearly our world is pushing lots of people who have subthreshold ADHD into full-blown ADHD categories. We have to look at secondary ADHD. We have to understand better how conditions like depression, anxiety, PTSD, substance abuse, other mental health conditions can mimic ADHD and as well as exacerbating it. So I should have a shorter elevator speech for the book. So I've been writing on medium.com. I've written actually 500,000 words for there in the last 5 years. So more than a book's worth a year of 100,000 words. So most of the book is written in smaller pieces, but actually, since I do lots of revising and editing, I don't know when I will be finished writing the book, and I'm sort of in early stages of negotiating with different agents, publishers, and it's all very preliminary there. So that's a non-answer answer for the next book. So Max asks a good question. Yes, do I prescribe bupropion or methylphenidate more often? And I wonder their, how their effectiveness varies. So I do have both talks about bupropion. I do have talks on methylphenidate. The methylphenidate one is asking, is methylphenidate really a stimulant? I think in many ways, methylphenidate is more similar to bupropion, Wellbutrin, than either of them are to amphetamine-based products. So most the biochemists, the pharmacologists who do the basic science disagree as to whether there's any so stimulant, amphetamine, and all of these drugs we're talking about do have dopamine transporter blockage. So they have reuptake inhibitors. They also reuptake norepinephrine to varying extents. They're similar in that they're in that category. They do vary specificity and strength, but the amphetamines also force extra amounts of dopamine to be released from the vesicles. So you're getting a bigger hit for your neuron that's releasing it, which probably increases addiction potential, increases likelihood for psychosis, but also clearly amphetamine-based products, every single meta-analysis do better than everything else, and they do substantially better in terms of just effect than methylphenidate products. And most of the meta-analyses that I've seen, again, it's amphetamines are up here, methylphenidates below it, and methylphenidate may be at the top of the category of non-stimulants, but it's clearly in that category versus the amphetamines. So I actually use bupropion probably more than I do methylphenidate. Again, in terms of clinical response, people seem to have roughly similar rates of response. Again, both of them seem to have lower rates of problems that the amphetamines do if you need to avoid that. So again, I've talks on all of those in more detail. I'm not sure if I've answered the question. So Johnny Greens asks, post-industrial illness. I think we're still causing industrial illness as well as post-industrial illness. But yeah, I mean, part of my theme, so my book that's still in the works is not just narrowly focused on computer technology, social media, bombardment of information, and interrupting our stream of consciousness and attention, which it is, but also how industrial contaminants like lead, like plastics, are also seeming to have ADHD like generating effects on the brain. So, Antaresta Magome, and sorry if I'm butchering your name, says, do I have experience with Ritalin long acting? Ritalin LA long. Started with 20 and it feels weak. I was on Ritalin short acting, 20 milligrams a day. So the general rule of thumb is if you are switching among short acting to long acting products, the expectation is that the same number of milligrams a day should be effective. But that means if you're taking 20 milligrams twice a day, the expectation is that 40 milligrams a day is what will be the starting point or target point or likely area. So if you were taking 20 milligrams of immediate release and it was only giving you 5, 6, maybe even 8 hours of benefit, but you really want something that's working for 12, 16 hours, then, I mean, many people try Ritalin immediate release twice a day before moving up to a long acting. But if you are expecting equivalent doses to feel equally strong, one's an immediate release and one is an extended release that's released over twice as long a period, you should expect a much smaller effect from the same milligrams because at any instant, you're not getting the same amount at receptors. So, So Maximus is giving me encouragement about the book. Yeah, so I mean, as I did somewhat in my Trump book, I tried to, I had a whole chapter on stigma and how people, and that's part of the reason I think the ADHD community hasn't wanted to talk about any connection between ADHD and more common everyday attention problems because it is too easy. There are lots of people out there who say, "Oh, I forgot to pack my lunch today," or "Oh, where did I put the car keys? Oh, I must have ADHD." Now, that may actually be their first wake up call they have ADHD. It also might be that the kid was sick and had a fever and there were distractions that morning. And no, you don't have ADHD. You just had a bad morning or even a bad 2 seconds as you left the house. So I think finding ways to add nuance and increase education is good, but yes, part of it is there will still be people being confused and misidentifying things. So Bear Jobs asks, how do I find a good diagnosis and plan for ADHD and depression? His son has been trying cognitive behavioral therapy and for depression and ADHD meds, and nothing is working with his therapist and psychiatrist. Um, One resource in many communities across the United States is CHAD. That's Children and Adults with ADHD. NAMI is another one. It's just more general mental health conditions, but these are patient-oriented and centered organizations. But many of them have lists of local resources. In this day and age of telemedicine, many people are comfortable just going online, so you may not even be restricted to your local community. But I mean, first, my approaches start with the people they're working with and asking them why, is this what you normally see? A lack of response? And if so, I should go elsewhere. Do you think there are reasons you're identifying for why my son is not responding to your approaches? I mean, sometimes it's practitioners who don't know much of what they're doing. Sometimes it's practitioners who just, for one reason or another, are not a good match. They may be competent in other areas, but they look like the creepy grandpa who molested them as a kid. I'm going way off, but there can be all sorts of non-specific reasons. That's a bad match, impairs someone getting good use of therapy, specifically talking therapies and including medications. I mean, with the CBT, one of the best predictors of CBT success for ADHD and for CBT for other conditions is the person doing their homework. And it can be hard to do homework if you have ADHD, but CBT also is clearly one of the therapy approaches where there is very good evidence that the training and the expertise of the practitioner is strongly correlated with outcomes and results. So lots of people say they're doing CBT, but if they're not really doing it, then you might not get much results. And more specifically within CBT, there are a lot of very good competent CBT researchers and clinicians who know nothing about ADHD. So they try the standard CBT approaches, and again, those are not a good match, but there's very good books by Safran et al., Safren, and Solanto, Solanto. Safran, I think, was University of Pennsylvania and Harvard Connection group wrote that book. Solanto's one of the New York City. They both have sort of manuals for CBT designed and modified for helping with ADHD. They are best conducted with a experienced therapist. The Solanto book is specifically a group CBT. The Safran is individual or group. I've worked with extremely bright individuals with ADHD who tried to do a CBT regimen themselves, and I think I have a pretty high threshold for declaring someone highly intelligent. But even highly intelligent people, if you have ADHD, they're more likely to page through the workbook, say, "Oh, that sounds like a really a good idea. Oh, that's something I haven't tried. Oh, I know that. I do that already." And then they may try one tool, one technique for a day or two, and then get distracted, fall off track. And even highly bright, motivated people, it is really hard to do CBT by yourself if you have ADHD. So, um, so I hope that helps with Bear Jacobs. Again, local resources, check with CHADD, CHADD, or NAMI, NAMI, um, but also push back against the people who are already doing the work to ask them, am I just being impatient? Is this going to take more time? What are the benchmarks we are seeing? Who do they think might be useful to go to next? So PH Joy asks, do I prefer certain insurance companies when it comes to those on disability? So unlike most of my colleagues and peers, at least in San Francisco, but the data is nationwide, for most of my working career, a third of my practice have been Medicare patients. Most of those are on permanent disability. Another third have been Medicaid patients, so both low income and often disabled. Both of those systems, and the Medicaid system is, I was going to say controlled, managed differently in each different state. So in California, it is called Medi-Cal, and then each county also. So I have more probably experience with general safety net or organizations and for-profit insurers. I don't think so. I did have to join Anthem Blue Cross Blue Shield to actually see Obamacare patients 7 8 years ago when Obamacare started. So you had to be in as a provider in one of those networks. I don't. I mean, in the U.S., they are required to treat mental health conditions the same as they treat physical health. There's some of them, particularly Blue Shield of Northern California, particularly Kaiser, have gotten repeated lawsuits against them for failing to do a good job of that, at least in Northern California. I can't speak for others, but I don't, I think in general, I might be naive and Pollyanna-ish. 40, 50 years ago, I think many people who worked for insurance companies, including maybe some at the top, really believed that they were providing a service. They were helping ensure financial security of people who were at risk for having to spend huge amounts on medical or mental health issues. For decades now, insurance is the corporate entity that runs medicine in the United States of America. It's not controlled by doctors, it's not controlled by hospitals. There are big lobbying groups there on both behalf, but it's the insurance companies. They control the money, they control how it gets doled out, they control who gets to be seen, they control what services get covered. And doctors, by and large, have bow down to their rules and regulations, whether they make sense or not. So I don't particularly think one is good or better, or that they're likely to have dramatically different coverage, either for medications or for number of visits. So Bear Jobs is getting back to the son with ADHD and depression and finding trouble getting a good treatment. So a hospital inpatient, I'd say specifically if there's a university-based hospital, you are likely at least to find some practitioners who are at the cutting edge or are more informed about current treatments or are more likely to have dealt with what's called tertiary care, people who have not had a good response with their initial providers. Um, and the other thing is that these approaches, both for depression and ADHD, take time. So you mentioned he's been trying different things. It might be part of it might even be need to be sticking with one thing if you've seen a small amount of success in the hope that more pays off with time rather than repeated switching. Um, So PH Joy says, I've seen some mental health therapists that aren't covered by the insurance that covers the better physical therapists. Um, yeah, so of all doctor specialties, psychiatry not only has had one of the lowest rates of participation in the Medicare system, they've also traditionally been one of the fields of medicine with the lowest extent of providing in-network services. So there are many of my colleagues who do not take insurance. They will provide you with a receipt and you can submit it to insurance yourself, and you're probably going to get reimbursed at a lower rate, probably 50% for out of network versus 80% or more for in network therapists or psychiatrists. So PH Joy asks, what is my opinion of Vyvanse? Vyvanse in the US, I think Elvance in much of Europe, or at least Britain, I think Europe as well, is lysine attached to dextroamphetamine. I have a whole video on it. It's one of my more popular videos. So it's certainly not perfect. I've certainly seen people who had disappointing responses, but I would say it is the most popular single stimulant I've used for people with ADHD. And almost invariably, people who've been on particularly immediate release formulations of stimulants, but even compared to other long acting versions of amphetamine or methylphenidate, the first not symptom, the synonym, the descriptor people come up with invariably with Vyvanse is smooth. It feels smooth. It goes in smoothly. It's not jolting them when it suddenly starts working. It's not jolting them when they are when it's leaving their system at the end of the day. For some people, that's a downturn. So many people, it takes an hour to 2 hours to get full robust effects. It's so smooth and gradual. I do have a number of people who wake up an hour early, take their Vyvanse, and go back to bed for an hour or two. Um, and then when they wake up, it's working. But I think in general, it's a good option for many people. It's good that it's not just as of a little over a year ago now, it's been generic. There have been problems with availability. FDA in the US has increased the quota system so more can be made and should be available. But I've seen it work well for many people. So PH Joy responds or that he's preferred short-acting Adderall. So there are certainly people who like the flexibility, the immediacy of if they don't want to be taking it every day or all day, or if they remember halfway through the day, oh, I have a presentation in the afternoon, I need to be ready for that. So there is certainly, for many people, more flexibility. Um, and there's certainly people who take an immediate release form of Adderall in conjunction with Vyvanse. So Rock'em Sock'em asks, what are my thoughts on 3,4-MDMA? So part of it is there are YouTube guidelines about illicit substances, and I'm not feeling overtly censored, but they want people to be very careful in saying anything positive or encouraging about potentially illicit substances. So what I can say is I have not read a lot of controlled research on it, and I don't have enough patient feedback on how it may help. So MDMA does break down in the body into amphetamine. So you are getting amphetamine if you're taking ecstasy, MDMA. It's having more prominent serotonin effects. I mean, it's more than it's not just simply amphetamine in a different container. There is some recent research coming out that it may be particularly helpful as the real world experience suggests, creating empathy, creating connections between people. So that's about all I'll say there, I think. If there's enough interest, I may do a whole talk on it and find ways to be careful around YouTube not wanting to promote potentially dangerous substances. So PH Joy asks, how does Ritalin and Adderall different from a quality cannabis product? And I'd say it differs vastly in terms of, so again, Ritalin and Adderall primarily working strongly on promoting dopamine and norepinephrine release. Adderall also boosting the amount that's released. Cannabis is acting at least primarily on cannabinoid receptors in the brain. Um, I do have a talk on marijuana. At the surface level, that the most common side effects of taking cannabis every day look like a really poor match for ADHD. So we know decreased motivation, decreased organization of thoughts, decreased energy are measurably there for people taking cannabis on a daily basis. But I've had a handful of individuals who felt that cannabis worked better for their ADHD than anything else. And there is actually a small amount of research suggesting that's possible. So PH Joy is there with a question before I even saw it, asking any thoughts on mixing ADHD drugs and cannabis. So my thought is to do it cautiously because I think for even though cannabis itself may help a small segment of people with ADHD and help quite well, I think there is a tendency to use one as an upper and one as a downer. So you're feeling too revved up from the day. Maybe you did take too much ADD medication. Maybe it's your ADD, but then you're taking a downer at the end of the day. Cannabis, being highly fat soluble cannabinoids, has a long half life in the body. So you may have hangover, lethargy the next day, which, so I would be cautious because, in general, just like there's warnings against using benzodiazepines, Valium like drugs, Valium, Ativan, Klonopin, Xanax with stimulants. I've seen a tiny, tiny number of people where they seem to be a good, viable long-term option. I've seen many people who came in who felt that it was working perfectly for them, and one or the other direction got into problems or troubles. And almost always, when we tapered down off of either the upper or downer, they did better in a more sustained way. So Electron, what do you recommend students with ADHD do to find success at university or college? So one thing to start out with is that the majority of colleges, and maybe less so with some of the commuter colleges, community colleges, but certainly most of the residential liberal arts general colleges in this day and age have university health centers and with specific expertise, knowledge, skills, educational approaches for people with ADHD, as well as for people who don't have ADHD, special how to study, how to manage your time, how to seminars, classes. So, yes, university health systems can be slow moving or clogged up, but I've seen many students who were reluctant to even reach out or use their resources, and on many college campuses, they are there and readily available, and in many cases, even can help navigate or negotiate between the student and individual teachers for accommodations or other. So that would be the starting point for help with success. I would say going off to college is often getting back to Dennis's initial question of when one of the times that kids who are particularly bright kids, particularly kids who had supportive parents, may have done very well in high school. And when they go off to college, there are many new distractions, many new friends, people, opportunities, substances, all sorts of things to pull them off track, much less structure to, mom isn't there to see if they're in bed at 11 o'clock or to remind them to put their phone away. Mm. So going to college is certainly historically a time when many people manifest ADHD symptoms at a clinical level who hadn't previously. So this may be not politically correct to attack or describe certain systems. So the question from Big Dog is, why does Kaiser underdiagnose ADHD? And underdiagnoses Big Dog's phrase. So I worked for 30 years in Northern California, where there's a strong Kaiser presence. I think the data is overwhelming for general medical conditions, diabetes, high blood pressure, many other sort of very common diseases, conditions that cause lots of debilitation problems. Kaiser does substantially better than the general US medical system does in treating those. And a big part of that is a lot of those conditions, the more the patient is educated about what's a good diet, of when to take the medications, of how do you deal with it if you forget your medications, what are systems to remind you. So lots of patient education. Kaiser is very good at that because they've seen investing in that leads to better health outcomes. So they do a good job overall. That doesn't mean every individual's had a good case. Mental health, and I know, and I always preface this by saying, I know individual psychiatrists, I know individual psychologists, I know individual social workers in the Kaiser system who I'm convinced are intelligent, caring, good people. But overall, the Kaiser system hasn't figured out an efficient way to leverage their educational model to mental health. And very clearly in Northern California, and this is my assessment or attribution of their motives, their business policy is to have as many people go outside of the system as possible and just pay out of pocket. Um, that saves them lots of money. So they have lots and lots of barriers to see the highest trained professionals. They have long waiting lists, and these are not, those two quests or statements are not just my subjective assessments. They have been sued multiple times every several years in Northern California, 4 to 5 years, sued for almost exactly the same things time after time. That is having too long a delay to get into a trained professional. That is having people at lower levels of training, essentially social workers, making prescription or medication decisions that the psychiatrists are only signing off on. And particularly, they're concerned, I think, I mean, so within the system, not only is mental health the problem, but ADHD, they are well known for having extremely low rates of people being on stimulants, getting again the medications that are most effective. I think they've crunched the numbers and see those as people who are potentially problems for their system and can encourage them to go elsewhere. The positive spin is that, yes, there are good CBT approaches for dealing with ADHD. So requiring people to go to a class or learn more about their ADHD in conjunction with being on medications is probably a good practice. But if it's not administered well, then it feels more punitive or restrictive to many patients. And the other thing I should say is my sample size is skewed by if someone's completely happy with the Kaiser system for their ADHD, I didn't see them. I wasn't a Kaiser doctor. But I saw many, many people who chose to pay out of pocket for their mental health who had Kaiser insurance. Um, so I'm sort of I'm losing track of I clicked. So PH Joy asks again, I always did my homework usually and I excelled, but I always took more effort and time than the average A plus students. I have so many things to do just to keep house and keep up with myself a mess. Yeah. So another, I mean, going off to college was one classic time people presented with ADHD. The second one is when people finish college, because even though, I mean, in particularly, I want to say back in my day, there was much more hand-holding, much more support, much more structure from universities today than there was 30, 40 years ago. That's not just, it's measurable, it's robust, it's extensive, it's true. So there are many bright people who can navigate the college situation, but then they get to the workplace and their ADHD is manifest or problematic. And then furthermore, and this is one that I think has been underpaid attention to by the ADHD field, and part it feeds into the trivialization of ADHD. There are people who found a career niche or path that was well suited for them. They may have been sort of eccentric or had did it their own way, but thrived. But then when they retire, that's when their ADHD becomes most manifest because they no longer have any structure, something interesting guiding them along, or something, a plan for what to do, and they drive their partners nuts because they're puttering in the house and they don't know what to do. So retirement is also one of those transition times. So, and I see I have a lot of questions today. I probably will not get through them all, so I'm going to try to answer them more briefly. Big Dog says he has a twin brother with schizophrenia. Should I try ADHD stimulants? High risk. I would not feel comfortable. There would not be any other information you could give me that would make me comfortable prescribing stimulants to you. And not, well, one exception would be if your twin brother was not related to you genetically. But since this is before IV fertilization era, I'm assuming, maybe not. But if this is really your twin brother, actually any first degree family member, if a parent, if a sibling has clearly diagnosed schizophrenia, psychotic condition, I am not comfortable prescribing stimulant medication. And stimulant should be amphetamine based. There is some suggestion that Ritalin methylphenidate may be safer. Actually, a fair amount right now. So on to rest but ask, should I transition from short acting to long acting Ritalin? So one question is, how well is short acting working for you? If it's working well, if there's not drop offs in mood, energy, focus as you're going off or ending at the end of the day, if you're remembering your doses, if it's giving you flexibility, that may be a viable strategy. There is lots of claims and speculation and only a tiny bit of rigorous research. So there's some suggestion maybe rate of addiction is lower with the long acting than short acting. I haven't seen convincing solid data. Is the risk of psychosis different from short acting and long acting? Are there other there's lots of claims and not a lot of robust evidence. But so I'll leave it at that. And PH Joy points out life structure isn't as narrow now as a free adult, so he struggles to keep house and stay creative, which is keeping him stimulated, but invites mess. So yes, as an adult, there's a lot more to manage, and that's tricky. And Redfern also points out that something many people learned in the early days of COVID, that being on site helped him, he could function, or he, Red, looks like a picture of a he, sorry. They worked well on site with their ADHD. Working remotely, it was too difficult and derailed their career. So that's not unusual, but there is a lot of structure, a lot of reinforcement. I mean, there can be negative aspects of working in person on site, but if everyone's going to lunch at the same time or about the same time, or you see people leaving, it's much harder for you to forget to eat lunch that day. It's much easier to have reminders to get projects in on time. You see, there's much more reinforcement that what you're doing matters and that people are counting on it, and hopefully that people value it. Um, So PH Joy asks, do I know of any resources to seek out for new primary care providers, physical therapists, mental health care providers, and perhaps what insurance companies may accept or not? I'd say, unfortunately, in the US right now, insurance is largely tied to work. I think that's silly and bizarre, but it is. So usually you have limited options through work. And I mean, because otherwise, just doing the amount of legwork and research to track down who are the good primary care folks in my area, what are each of the insurance plans each of them take, and those can change. And the same with physical therapists, same with mental health. That logistically, I mean, maybe AI will help us do a good job of that in the not so distant future. I'm not aware of any system that does now, but usually there are restricted options and very few options as to what insurance is really available for you at affordable cost in this area. And then it's usually looking within your insurance network as to what providers are available. Um, so, and PH Joy is heading out that even though cannabis is legal in the state they are in, his former healthcare provider was fired for allowing patients to use cannabis while they were taking Adderall. So I have heard of that happening. Again, I would say for the providers, if there are any listening or watching, what's really important is to document, if you are aware of this, that you are aware of what the side effects, potential side effects, any side effects or adverse effects you're seeing, and that you document also if you're seeing benefits and how you are confident that some of those benefits are attributed to the cannabis may help save your job. So Bibbs says they take 70 Elvance, 5 ants, and 5 milligrams 1010, I think, which a day, and that really works for them. And they've seen an improvement of their appetite is a lot better on their medication, and that's great. But how can that be? So I don't know. So I would be speculating. Again, in general, the stimulants do have some appetite suppressant properties. Those do tend to wane with time. So people grow tolerant to them before they grow tolerant to the benefits. What I've seen, I actually used this as one of my diagnostic tools. So one of my tools in the old days, I had a home office and there was a house at the street level and an entrance at the end of the driveway, which dipped down. The only people who ever went to the wrong address were the people with ADHD, because I always said, anyway, my other fake screening for ADHD was if someone said, "Oh, it was 4 o'clock and I realized I hadn't eaten lunch all day," that's almost always a tip off for ADHD. Most people don't forget things. So if part of it was not being aware of your own proprioceptive input, part of it might be poor time management and paying attention to what your body is needing or doing. So maybe that's explaining some of the difference. So Cosmos Princess, thoughts on taking Adderall with Wellbutrin together? Should they be staggered? So most often when I've had some people who took them together and took the same dosages every day and usually found they could get away with a lower dose of Adderall when it was with Wellbutrin than if they took Adderall alone. I've also had people who were taking Wellbutrin daily and then taking Adderall when there were specific projects or tasks that they felt they needed more help with attending to. Um, I'd say as long as you're aware that they're at least additive and maybe more so, that again, the side effects like agitation, increased heart rate, increased blood pressure, having Wellbutrin on board makes it more likely for that specific dose of Adderall. But if you're getting by with a lower dose of Adderall, it may be a net benefit for you. Um, Sorry, this clicking is blocking. And PH Joy asks, why did my psychiatrist ask me if I showed signs of OCD before prescribing Ritalin? So I do have a talk on OCD. OCD, even though many people think it is sort of the perfect opposite of ADHD, so someone's meticulous and organized and obsessive about details, up to a third of people with a formal ADHD diagnosis have a condition in the OCD spectrum, um, meeting clinical definitions. So that's substantially higher than in the general population. There seem to be shared genetic factors, and it might be easier if you conceive, again, attention deficit isn't a deficit in attention. Both of these conditions have to do with control of attention and control of motivation and how action and attention and behavior are regulated. Some people also think, and I think there are some cases where this OCD spectrum issues may be a response to trying to deal with ADHD. So if you know that you have a tendency to misplace things or forget things, and you might set up obsessive rituals where you have a checklist where you pick up the pen and put it in the wallet and do X, Y, or Z to make sure you have everything because you've been burned by your ADHD. So it may be a protective response. Whether stimulants or other drugs worsen OCD, there's some individuals who they seem to worsen, some individuals actually seems to help make them better, and many more who they're probably somewhat irrelevant. So Rachel says she's 49, masked my whole life, struggling to function, just started 18 milligrams Concerta and a broccoli quiche for lunch and making cupcakes from scratch. And she feels like she just started her life. So congratulations. I'm glad you found something that seems to be helping and that you are engaging in activities you're enjoying and doing things you like. And I'm sorry that it has taken so long to find out what might be going on and what might help. That's not uncommon. Yeah, so PH Joy is talking about how to have life be less intrusive and invasive. And one big one, I don't have ADHD, at least that I'm aware of, and I don't think I've had. But I don't have any notifications turned on any of my apps or phones because they're just so distracting to anybody. So Nathan Swoop asks, any thoughts on Qelbree and Adderall combination for adult ADHD? So I do have a talk on Qelbree in this series. One of the things this points out, and it's a really common question, there's almost no formal research looking at stimulants in combination with other agents. Probably the most, or the one maybe with the largest, would be on guanfacine. So what I'd say is again, remembering that some of the actions are overlapping in terms of promoting dopamine, promoting norepinephrine. So side effects or benefits are probably at least additive, maybe more than additive. And I would say just approaching it cautiously and starting with low doses. I don't know of absolute contraindications for the two specifically together. So PH Joy asks, how does Concerta compare with Vyvanse and Adderall? So and this is my clinical bias, of Ritalin methylphenidate products, Concerta far and away, I would say Concerta was the Vyvanse of the methylphenidate world before Vyvanse came around. So I have lots of people, you know, it works. I mean, part of it, particularly if you have the brand name or some of the generics, the delivery mechanism is an osmotic delivery system. That means there's much less variability day to day and person to person, and less dependence on how quickly things are going through your digestive system, and less dependence actually on acidity. So Concerta tends to be more consistent day to day if it's the brand name osmotically delivered. Um, so I've seen lots of people like it, but again, as with everything, I haven't seen everyone who doesn't work for everyone. So I'm almost out of time. I'm sort of skipping over some of PH Joy's comments. And yes, about they ask about nicotine. So I do have a talk on nicotine and ADHD. I think it's directly saying nicotine rather than cigarettes. So nicotine seems to be helpful for many people with ADHD. There were pharmaceutical companies who were developing nicotine agonists, nicotine drugs that act on positively on the system, and that abandoned them. I still have not heard a clear reason why. Um, I don't recommend or support smoking or even vaping as its health hazards. So that's problematic with nicotine. So JJ's was on Lexapro for generalized anxiety disorder, just got diagnosed with ADHD, I'm presuming, and is on stimulants for 3 months. And now the anxiety is worse. So I can't make specific recommendations since I don't know everything about your history. Some of my thoughts would be one is to make sure the stimulant dose is absolutely lowest available, because if you're too much stimulant can rev someone up with or without ADHD, more commonly without, but even in the setting of ADHD. Two is there's many people who can't tolerate stimulants at all. And then after they've tried guanfacine and are on a stable dose of guanfacine for the ADHD, if they still need stimulants, then are often able to tolerate stimulants with guanfacine in place. Um, so that would be my starting point. And I also have talks on panic because I think often stimulants can feed into sort of a panic loop that you can sort of train your body that, oh my God, I'm feeling this physically from the stimulant. That means I'm going to or have to be anxious. And some of that can be feedback loop can be broken up with the cognitive behavioral therapy. So JJ also asks if I've heard of the 7 subtypes of ADHD and what I think of them. This may get me lots of flack and in trouble, and my time's up. So if this is Daniel Amen's 7 subtypes of ADHD, which has sometimes been 7 and sometimes 9 and sometimes 13, and claiming to have a distinct PET scan profile of brain activation for each subtype, I think there's probably a kernel of truth there. I mean, clearly there's a variety of types of ADHD, but his ability to the ability of anyone else to replicate what he's seeing in terms of distinct subtypes is highly, well, it's non-existent. So I think it's exaggerated, and people that I've seen who've come to me or went to him, his clinics, to get PET scans were treated in a very formulaic manner and not as individuals. Again, those are probably not the people who are happy with him and delighted with the service. So it may be a skewed example, but that's what I'll say there. So thank you so much. I do have other obligations. So glad that this helped or was interesting to so many of you. Um, I'll save the remainder for later, and I think I'll be able to see them and find them and preserve them. So that's all. Thanks for coming. Stay healthy, stay happy, and I'll be back next week.